thought maybe Gloria or that. I don't know where she is, but she may have.
I know. I just.
She may be saying something else.
Yeah. I'm not sitting.
From here to get
sit next to this guy in the blue shirt.
Yeah.
Say, Jeff. Excuse me.
Yeah, I think just pull out some of these. Yeah, I think so. And there is a lavalier here, Mike, if you down here, if you'd like to.
Don't steal my slide.
Yeah, please. Well, ladies and gentlemen, why don't we get started? I want to welcome you all to the Woodrow Wilson Center. Those of you here in the auditorium and those of you watching live on the internet. My name is Jeff DeBelco. I direct the Environmental Change and Security Program, but also am very active along with a lot of other collaborators and colleagues here at the center on a new global health initiative. So we are thrilled today to have a session entitled Emerging Pandemic, Costs and Consequences of an Avian Influenza Outbreak. We're very lucky to have two distinguished guests, Helen Branswell and Michael Osterholm, to help us understand the status of the H5N1 avian flu threat and place it in a larger economic, political, social context, connect it to some of the portfolios of all of you in this diverse audience, and what a pandemic might mean for all of us as individuals as well as everything we're working on in our day-to-day. Today's session is in fact the inaugural event of the Wilson Center's new Global Health Initiative, an effort that is spearheaded by the chairman of the board here at the Wilson Center, Ambassador Joe Gildenhorn, and of course Wilson Center President Lee Hamilton. It's a collaboration of many of the programs. As you can see on your participants list, we have 4 or 5 different programs that are co-sponsors here today. So I'm thrilled that all of us have this means to come together around this cross-cutting and interdisciplinary issue of health that's critical for regional programs as well as topical programs. Gives us an opportunity to promote this dialogue in terms of issues of health and their connection to broader foreign policy issues and policy here in the United States. The initiative will have a number of focuses: health's impact on development, the role of national and international institutions in global health policy, something I think we'll hear a lot about today, infectious disease, obviously what we're talking about today, and hopefully to some degree emerging health technologies. Please do be sure to sign in and let us know if you're interested in being on lists for this, and come to the Wilson Center's website, which now has a devoted Global Health Initiative page. We have programming already set up for the fall and more that we hope you will join us for. So let me introduce our guests so that we can get on with this discussion. To my immediate left, Helen Branswell is the medical reporter for the Canadian Press, Canada's news agency, and she has been for the past 5 years. She's based in Toronto, and her work focuses heavily on infectious disease, including being in Toronto and being the lead coverage of the SARS epidemic in 2003, which I think will have some interesting insights for what we might be facing. Since January 2004, she's really been focusing on the H5N1 virus and talking about the pandemic threat and reporting on that and what the real global efforts to deal with that are. Prior to coming to the medical beat, she spent 5 years as the London correspondent for the Canadian Press. In her career that spans 25 years in journalism, she has a range of both awards and fellowships, including the 2004 Knight Public Health Journalism Fellowship that enabled her to spend a year at the CDC working with influenza folks. So it's terrific that our journalists actually get to spend a year really getting in depth on a topic, so we're very pleased that she's here. Michael Osterholm, who will kick us off, is the director of the Center for Infectious Disease Research and Policy and associate director for the Department of Homeland Security's National Center for Food Protection and Defense, as well as professor in the School of Public Health, University of Minnesota. Obviously, a busy man and somebody who cuts across, which is obviously critical for dealing with this topic. In June 2005, Dr. Osterholm was appointed by Mike Leavitt, Secretary of the Department of Health and Human Services, to the newly established National Science Advisory Board on Biosecurity. Dr. Osterholm also served for 24 years in various roles in the Minnesota Department of Health, the last 15 as the state epidemiologist and chief of the Acute Disease Epidemiology Section. Many of you also probably saw, as did I, and really were taken by his piece in Foreign Affairs here just an issue or two ago, part of a discussion that I would maintain anyway has really brought this issue to a much higher level of focus, certainly in this town, and with a much broader set of folks paying real attention to it. I think in some ways looking at just the affiliations of the people in the room, a testimony to that. So we're very pleased to have Mike kick us off, and I'll turn the floor over to him.
Thank you, Jeff, for the introduction, and I'd like to thank all of you for being here today and for the Wilson Center for allowing this activity to take place. It's one that I could say at the outset could not have taken place any later than this, I think, to help wake people up to what is, I believe, an inevitable situation coming down the line. Let me make just two comments as I start in what will be a relatively brief and unfortunately somewhat high-level overview, and we'll get it to questions and answers. But I've been in public health for 30 years at the ground level, having been involved in the earliest days in things like toxic shock syndrome and HIV/AIDS, antibiotic-resistant emergent infections, bioterrorism, and so forth. And I can tell you that without a doubt, if you were to add up my entire public health career concerns, worries, and in some cases nightmares, if you added them all together, they collectively do not meet the concern, the worries, and the nightmares that I have about the issue of a pending pandemic of influenza, and today I'll share with you that construct. The other thing that I want to give you the sense of is that in 9/11 of 2000, actually I published a book called Living Terrors, a book on bioterrorism and the concerns that we had in terrorism in general. And in that book I specifically talked about the World Trade Center towers and the Al-Qaeda. And if you had asked me in the year between 9/11 of 2000 and 9/11 of 2001 what the likelihood of the events of 9/11 unfolding as they did, despite what I had talked about, I would have told you probably it was 1 in 10,000, 1 in some number like that, but it was a real risk. I want to leave you at the outset today that the risk of another pandemic of influenza is 1. It is going to happen. It is not if it's going to happen, it's when and where and how bad. And that, I think, has to be the understanding that we begin with today as we talk about this issue. This is probably the single most important slide I have in my entire repertoire of thousands of slides. And what this really points out is we live in a very different world today. Just in the last 150 years, we've gone from a world population of about 700 million to a world population today of 6.5 billion. In 1918, one of the dates we'll come back to, the world had 1.8 billion people. Today, roughly 1 out of every 9 people who ever lived is on the face of the earth. In addition, we have changed how we get around this world, and this concept of a global, one-stop, non-stop world is a reality. Although we have not increased the speed at which we get around the world and from the 1950s with jet travel, what goes around the world and the dependency that we have on other parts of the world for our everyday lives is huge. That is an overlay for understanding today's concerns about pandemic influenza. Now, let me just give you a very brief primer for those in the audience that have expertise in this area. You can take a brief break. For those that don't, let me just remind you that influenza type A, the kind that causes pandemics, and causes the annual intra-year pandemic concerns that we have with annual flu, basically is made up of a series of different viruses that can be characterized by their hemagglutinin antigens and neuraminidase antigens, HA or NA, or as you now have come to know it, H in some number, and I'll come back to that. Human disease historically has been caused by 3 subtypes of hemagglutinins, H1, 2, and 3, and 2 subtypes of neuraminidase. These are key because the hemagglutinin is a very important part of the virus in terms of getting into the human cell. If the hemagglutinin doesn't have the right receptors or right chemical structure to get into the human cell, it may be floating out there in birds or whatever, but it's not likely to infect humans. The neuraminidase is a very important part of the virus that allows it basically to get out of the cell, so that even if a human gets infected, will they themselves become infectious and capable of transmitting the virus? All known subtypes of influenza A can be found in birds, but only 2 subtypes, H5 and H7, have caused severe outbreaks of disease in birds, as we now know it today. The natural reservoir for influenza viruses, all of them, is wild aquatic birds. And not just in the Far East, although that has been a very important source, but across the world. But for whatever reasons, and we can go into those on a scientific basis, they have not then made the jump or change in their hemagglutinin structures and neuraminidase structures to become human pathogens, only but rarely. Now, the way influenza virus gets out of the bird population, and in this case from wild birds to domestic birds, and there is a difference, by the way, onto humans, is the virus has to change. There are 2 ways that a virus can change to become this new virus, the one that we're most concerned about. One is a concept called reassortment. The other one is one called recombination. We have traditionally thought of pandemics, the emergence of a new flu virus out of the wild bird population into humans, as a result of reassortment. Reassortment occurs when this very promiscuous, indiscrete, and sloppy virus is in a lung cell of, we used to think pigs, potentially humans, and it comes to close contact with another type of influenza virus, which is already human adapted. This cartoon from the New England Journal of Medicine shows on the left side, in this case, H5N1, this unique virus that we'll be talking about that has caused such concern. And if it were to infect either in a pig or a human population and co-infected with an already existing influenza strain, such as the common H3N2, which is the one that we see year after year and was the cause of the last pandemic in 1968, these 2 will swap genes very easily. There are 8 genes in the influenza virus, and if it acquires enough material from the human adapted strain, keeps the important disease-causing and immunologically distinct characteristics of the new strain, Walu, you get a virus that now will infect humans and will cause lots of problems. That is how we traditionally have thought that pandemics start. H5 has not done that since its first documentation in 1997. Instead, what we see is a series of what we call point mutations, these gradual changes where the virus keeps passing and passing and passing through living specimens, i.e. primarily birds, and with each of those passings, the changes occur that get it closer and closer to what would be, in a sense, the result of a cataclysmic event like a recombination. Why might that be a possibility? This gives you some sense of how that world has changed. In 1968, the year of the last pandemic, there were 790 people in China. Today there are 1.3 billion. In 1968, in a very different social, political, and economic time, there were about 5.2 million pigs in China. Today there are about 508 million pigs. In poultry, there were 12.3 million chickens. Today there are over 13 billion. And I might add that the average life expectancy of a chicken today from time of hatching to harvest is about 18 weeks. So that you can see in a year's time there's actually triple this number in the sense of what passes through the system. What we have today is an ideal incubator, kind of the forest fire of forest fires potential, because it's instead of having a mountain state park or a national forest somewhere, you basically have a virgin forest from San Francisco to New York kind of thing that could burn. This virus will not burn itself out in the current environment of Asia because of this ongoing potential for the virus to be transmitted. Each one of those transmissions, each one of those infections results in another opportunity for this virus to continue those mutations that accumulate over time, and is what is driving, we believe, the concern for ultimately unleashing a pandemic strain. Now, to understand pandemic influenza, epidemiologically, pandemics are an epidemic that becomes very widespread, affects a whole region, a continent, or the world. Now, we got to acknowledge that technically, every year we have a pandemic of influenza in the sense of the seasonal flu. That really does meet that definition, but that's not what we're talking about with a pandemic. What we're talking about really is this new virus emerging for which there is very little human protection from previous experience with the virus. The virus may have characteristics that make it more likely to cause severe disease. There's been at least 10 pandemics recorded in the last 300 years. The most notable one is the 1918 one. But let me tell you, as we start to study previous ones, 1830 to 1832, 1766, there clearly were other pandemics that had an impact that for the time and for the population may not have been that dissimilar from 1918. In 1830 to 32 was similarly severe in a smaller population as we saw in 1918, 1920. You'll see lots of numbers thrown around about how many people died in 1918, 1919. Let me just say I refer back to a publication that recently appeared in the Bulletin of Medical History, which basically was an examination by a group of historians that went back and actually took country-by-country data, and they came up with an estimate of a minimum of 50 million, and they actually said in there that they believed it could have been as high as 100 million people perished in the 1918-19 experience. Now, pandemics occur when a novel influenza strain emerges from the bird population through other animal species into humans that, A, can be readily transmitted between humans, so it's got to have the right lock and key to get into the lung cell, i.e. that hemagglutinin has to change just enough, keeping the bad disease-causing properties, but at the same time now readily infecting humans. Today, H5N1 only has a little bit of that. It occasionally gets into humans, but not readily. 2, it has to be genetically unique, meaning that there's not a whole lot of us out there that have pre-existing antibodies, so that when it starts to spread, it will spread unchecked. And 3rd, what really makes it a different situation is increased virulence, or the ability to cause disease in a different way. And I'll share with you that not all influenza viruses, even pandemic strains, were created equal. Pandemics have differed in terms of their population-specific mortality rates and cannot be characterized by a single risk predictive model. So today when people talk about pandemics and previous history, please do not allow yourself to sink into that idea there's only one kind of pandemic. There is not. And I'll show you this right here. These are the 3 pandemics documented during the 20th century. In the United States, for which we have probably some of the best data, these are data from Lone Simonson at the NIH, you can see that in 1918-19, there were roughly 500,000 excess deaths in this country. In the pandemic in 1957-58, in 1968 and 69 respectively, there were 60 to 40,000 increased excess deaths, which today when you think about influenza, every winter kills between 35 and 50,000 Americans. You can argue that the bottom 2 numbers, while for the population being smaller then than it is now, still it wasn't that major of a departure from what we're talking about could potentially be the situation. Now, the 1918-19 pandemic is one we must study, and I'll come back to that in a moment because I believe the H5N1 virus, if it is to be the pandemic strain, and again, I said there's a chance of one, there will be a pandemic. I'm not going to tell you it'll be H5N1. Everything in my science bag tells me that that's the case, but tomorrow we could be surprised and a new virus pop up somewhere else, reassort, and spread. So we have to keep our eyes open 360 degrees across the board. But in that particular pandemic, we now know retrospectively it was an H1N1 strain. Of course, we didn't have virologic techniques back then. We have now completely sequenced this entire virus from specimens, either pathology specimens from soldiers who died in 1918, in which we have excellent records in the military, or from exhumed bodies that came from permafrost. And collectively now, the virus has been totally sequenced. 200 million to 1 billion people were infected. As I pointed out, more than 50 to 100 million died. Killed a disproportionate number of healthy young adults, the W curve. Traditionally, when we think of pandemic influenza, or for that matter, inter-pandemic years, like every other year, we expect to see a U-shaped curve with the highest rates of death at the very young and the very old. In the 1957 and 1968 pandemics, that U-shaped curve generally just was pushed up at all levels, i.e. a rising tide. In 1918, it was very different. It was a classic W-shaped curve affecting the very healthy of us the most, and I'll come back to that in a moment. Another thing that happened in 1918, a summary of 13 studies throughout the world actually demonstrated that among pregnant women, 23 to 71% died, 55% overall median death rate, which also is an important, in a sense, observation because pregnancy in the human condition is the single most precarious immunologic time in our lives because a woman is carrying something that biologically in part doesn't belong there. It's not her. At the same time is working very hard to protect that thing from any other insult. And immunologically, the immune system is at a very, very precarious trigger point in terms of what happens. So if you have a virus that can actually impact the immune system, you can see some very deleterious effects as we saw in 1918. That makes of great importance to us today because there are two recent studies that suggest that H5N1 is deja vu all over again in 1918. And in fact, a study from Kabasin Group and additional studies that will be coming out very shortly in several major publications support that, in fact, the H1N1 pandemic strain basically created an over-exuberant immune response in the host. That's what we call a cytokine storm. Why is it then that people 18 to 40 were at highest risk? Because who has the strongest immune systems in our population? You spend the first 18 years of your life generally building up your immune system, and unfortunately for the 2 or 3 of you in the room over age 40, it's on the way down after that. And so in a sense, it really goes at the very opposite of what we traditionally think of with influenza. It goes at the very healthiest of all of us. The clinical picture in epidemiology, as we now know it in Southeast Asia with those H5N1 cases we have, is this exactly, both in terms of the laboratory-based data and the epidemiology. This is a cartoon from a paper I published in the New England Journal of Medicine in May, which basically just shows this H5N1 in the upper left-hand corner, setting off a whole cascade of events in the immune structure of the host, ultimately resulting in the severe acute respiratory distress syndrome we see in cases of H5N1. Let me just tell you at the outset, in general terms, we are not much better able to handle acute respiratory distress syndrome in any number of cases today than we were in 1918. So don't go back and say, well, it's different today. It's not 1918. Unfortunately, folks, it is 1918 all over again, even from a clinical response standpoint. These are data which give you a sense of what I was talking about with the W-shaped curve. These are actual data from Boston. The top graph is the historic concept here of 1912 to 1916 for the months of September, October, and November. On the left axis there is actually the death rate per 100,000 population. And for the top graph, it's 0, 100, 200, 300, 400, 500. On the bottom, where it may be cut off for some of you down there, it's 0 to 9, 10 to 19, 20 to 29, 30 to 39, 40 to 49, 50 to 59, and 60 to 69. Note historically, the rates are highest in the very young for pneumonia and influenza-like illness and gradually increases with age. Again, this is a rate per population, so it's just not absolute numbers. Look what 1918 did from September to October in Boston, an event replayed over and over again around the world. Now the axis is 1,000, 2,000, 3,000, 4,000, 5,000, reaching 5,700 per 100,000 population, i.e. 5.7%. And you can see what happened is there was a slight increase, well I would say slight, it's still a tenfold increase based on historic data in the very young. But when you look at the rate for those 20 to 29 and 30 to 39, it approached almost 6% of the population died during that time. That's a remarkable concept to think about happening again today. And then, of course, it came down with over time. So that in a sense, this is what we all worry about. If we take the 1918 numbers, and people will throw numbers out all the time, and I can't tell you what if H5N1 happens and it follows this pattern, what it'll be like. All I can share with you is if you take today's population and extrapolate the 1918 data, meaning the exact rates of deaths and cases, you could expect to see in a state like Minnesota, where we have almost 5 million people, 3 million living in the Twin Cities, you could see 18,000 deaths in our city over a period of a year to a year and a half. But more notably in the United States, 1.7 million deaths worldwide. If you take the lowest possible estimate of 30 million all the way up to the upper bound of what was the 1918 number of 384 million. Just to give you a sense, remember HIV/AIDS in 30 years has killed somewhere in the neighborhood of about 30 million. That is a horrible tragedy, and yet in comparison you understand what we're talking about here. Now, we have this situation in Asia. The actual number of cases in the last several years is not completely clear. It's somewhere about 120 cases, 60-some deaths, but you can see the spread that has occurred both in birds and humans. What's the issues here in terms of pandemic preparedness? There are really three aspects: either prevention, treatment, or collateral damage response, i.e. what happens besides the pandemic. In terms of vaccination, I know Helen will be talking more about this. In terms of prevention, we have vaccination, antiviral therapy, and prophylaxis. With vaccination, let me just say that for those in the audience who are old enough to remember a slide rule as your primary mechanism for mathematical calculations, understand that today's vaccine procurement, development, and actual production doesn't vary a whole lot from what it did during the time of the slide rule. We have a couple of new tweaks on it, but we're basically producing the vaccine with chicken egg culture-based approaches the same way we did in 1950. It's grown in chicken eggs, takes 6 or more months to produce. The use of reverse genetics, one of the new techniques, does help us develop prototype vaccines. We do have a live attenuated vaccine now, but a very small part of the market still must be grown in chicken eggs. We need an immediate and comprehensive international program to develop a cell culture system for vaccine production with surge capacity. We can make some vaccine now with the current existing H5N1 strain. At the best, that will be a priming dose. Most of us agree that we'll need at least 2 doses of a new vaccine to protect against H5N1 if that were to be the emerging pandemic strain. We could use the current virus to some degree. The problem with that is you'll still need the circulating virus to really get the ultimate protection, just like annually what we need to do in terms of our changing the vaccine year after year. So that means we won't even have the seed virus till the pandemic begins, which if it takes 6 months means we won't even have any production for almost that time period. Current annual international capacity for influenza vaccine production using egg culture is approximately 300 million trivalent doses, or as we now have, or 900 million monovalent. That assumes a dosage of the current size that we use in our vaccines. As Helen will talk about, NIH has recently done its initial analysis suggesting they need 12 times the amount that we need to provide protection to an individual now with this, as opposed to what we use every day for H3N2. Now, we hope we can bring that number down, but it still means we're even going to have a shorter supply than this. Almost all the world's influenza vaccines produced in 9 countries, which includes only 12% of the world's populations. Make no mistake about it, just like in 1976 when we nationalized the H1N1 vaccine, part of the swine flu program, and wouldn't let any other country have it, any country who has a plant within its borders, I am convinced, will not allow that vaccine to leave that country's boundaries. So that, in a sense, we've already greatly leashed down the number of people who would even have access to any vaccine. Production capacity will not increase significantly in the next several years. Understand this is not about money anymore. Money is a necessary part of the equation, but it's about infrastructure. If I said to you today, we want to build a 150-story building in downtown New York, and we had all the money in the world we wanted, it doesn't matter, but I want it done by Christmas, there is no way in hell that will happen. It won't happen for years, even under a crash program. Today, for us to build this new vaccine infrastructure on a worldwide basis, and however we'll pay for it, will take years to occur. That's if we launched a Manhattan-like project tonight. Finally, new and more timely methods of production are desperately needed. In terms of the antiviral drugs, let me just say we're really only concentrated on the neuraminidase inhibitors, the two bottom drugs. The top one you know is Tamiflu. The top drugs, the M2 protein inhibitors, are likely not to play much of a role because right now most of the strains we have coming out of Asia are resistant to that drug and would quickly develop resistance if we use this on a widespread basis. Let me just point out here, we don't know if these will work. There are conflicting data which says, yes, they will work against an H5N1, but other data which suggest the cytokine storm, this immune response, is different than a typical H3N2 infection, and it may not work. So I would not for a moment suggest not working on this issue, but let's just be clear, we don't know. The second thing is I would tell you that, again, the same pipeline issues that are operative with the vaccine are operative here. People have these wonderful orders in for neuraminidase inhibitor drugs, which they don't tell you is will take years to fill, as given our current capacity and production. Let me just very quickly, briefly say we've got other issues, facilities and staffing. You have no vaccine, you have no antiviral drug, and I'll point out in a moment you'll have no masks for these people. Who's going to come to work? Where are they going to come to work? Right now we have gnawed our healthcare system down, even in the developed world countries, to the bone, and we're sucking calcium. The bottom line is we will be operating in gymnasiums and community centers wherever we can find space. And we have to wonder who's going to show up for work. Would you show up for work? Would your loved one show up for work if they were being exposed to a life-threatening infection every day with virtually no protection? Worker and patient protection will be key. Medical devices and therapy, we will run out of those quickly. We will run out of all the other drugs. Today, we have a global just-in-time economy that provides us all of our pharmaceutical products. Right now, we have major shortage in this country of 7 different antibiotics and 3 pediatric oncology drugs, all because of the fact one plant somewhere in the world makes them, and all it takes is just one glitch in that operating supply chain, and they go down. Under a crisis where we shut down borders, where we have a major decrease in international trade and travel, we will see tremendous collateral damage from other conditions which we routinely think of being treated for which now those drugs will not be available. They just won't make it through the supply chain. Other medical devices, let's take something like the masks I mentioned. Today, 2 companies in the world, both American companies, own well up to 90% of the market share internationally of a mask known as an N95 or a respirator mask. Today, those companies have virtually no surge capacity whatsoever to make more masks. Those masks are made offshore. In addition, their masks are actually made by obtaining raw materials from second and third tier countries. The bottom line is we'll run out of masks very quickly. And again, think of the panic and fear that will just be there. If I can't get a vaccine, I can't get an antiviral drug that will work, and I can't get a mask, what do I do? Ethical issues around allocation of resources and so forth will be huge. The use of recovered volunteers, how we bring these people into our system. They may not be healthcare workers, but they may be doing the work of healthcare workers if they're people who've had the virus infection and lived. Finally, corpse management. In 1969, in this country, the average time from a casket being constructed until it was in the ground was 6 months. Today, it's a little over 2.5 weeks. Today, we will run out of caskets overnight. Second of all, our crematorium capacity in this country is limited. We will find it very hard to process the number of bodies that we could expect to have. When that begins to happen, let me tell you, it adds a whole other dimension to the concept of fear and panic and what it means to know that we can't even manage the bodies that come from a situation like this, even with a relatively moderate pandemic. Finally, to the collateral damage response, everything from pharmaceutical products, food, equipment parts are all going to shut down with the global just-in-time economy shutdown. And I have no doubt it'll happen. In the Foreign Affairs piece, I extensively discussed the SARS situation, what happened internationally with it, and even still, as much as that was a very limited experience, and Helen will talk about that, the implications were huge. Finally, let me just conclude by saying, what do we do? Well, I think, frankly, from my perspective, we pray, plan, and practice. If Katrina taught us nothing else, it's not enough to have something on paper. It's also something of much greater magnitude than just that first chessboard step. It's the whole game we've got to figure out in advance, such as the private supply chain. It's not a matter of if, just when and where. Am I telling you H5N1 will be it? I'm not. I think it will be, but no matter, there will be more pandemics. If we can't stop tsunamis, hurricanes, and earthquakes, we surely can't stop pandemic influenza either. Lack of international political will and support right now, most of the world doesn't get this. I have to tell you, as much as our own government's done, we don't understand that this will make the catastrophic events of the recent weeks pale in comparison to what this will bring us. At a minimum, assume we'll have virtually no vaccine for the first 6 to 8 months, and then supplies will remain limited. And our best analysis right now, maybe 1.5% to 2% of the world's population would have access to the vaccine in the first 6 months. Even if we could protect our entire country, if we had that luxury, the global economy will still collapse, and we will have tremendous collateral damage as a result of that. And finally, I think given the virologic characteristics, the epidemiology that we're seeing, we have to understand that there is more than just a passing resemblance between the 1918-20 experience and the current H5N1. There really is a model here that we have to look carefully at. We can't be surprised if the levees break here. And I'm afraid, as a world, we still will be. We have to understand these are the implications. This is what we're facing. And if we do nothing else, we have to plan as if, what if this happens tonight? What if it's 1 year from now? What if it's 5 years from now? And we need to move all three of those together. Thank you very much.
While we switch PowerPoints, those of you who are standing on the side, there are still a few chairs in the middle if you want to come down and grab a seat.
I'm sorry? Sure. Is that enough? Yes, that's it. There you go. All right, thank you. Hi, welcome to my nightmare. I've spent about most of the last 2.5 years researching pandemic influenza in general, and the avian flu strain Mike was talking about, H5N1 in particular. That's the strain the renowned flu expert Robert Webster from St. Jude's in Memphis so eloquently described to me last November as the one that scares us shitless. In the time I've been working on this, I've interviewed hundreds of scientists and public health authorities, veterinarians, vaccine and drug makers, healthcare workers about this topic. While Dr. Webster's remark was the most eloquent and a little bit too graphic for my editors, I have to confess, all of those people talked to me in terms that I could not ignore. The urgency in their voices was just palpable. A number, including leading influenza experts, told me they all suffer sleepless nights. In that 2-year period, and I took a 3.5-month break to go to the CDC at that time, I've written 90 articles about influenza. To put that in a little context, I wrote 41 that mentioned the word cancer, which is hardly an insignificant medical subject, and I wrote 6 about diabetes. The Canadian Press, which is Canada's rough equivalent of the Associated Press here in the United States, conveyed my articles to the major daily newspapers and to the broadcasters and the news websites across my country. And they fell into the great news void. Or, if they were run at all, they were run on the back pages. For reasons I can't fathom, many news outlets in North America aren't paying attention to this story as a human health issue, as a global security threat, as a potential economic disaster. There are some exceptions, of course, and I certainly don't want to suggest that I'm the only person paying attention to this. But for most news organizations, bird flu, as people like to rather imprecisely call it, really hasn't been on the radar. You know the expression about ignoring the elephant that's in the room with you? I think of pandemic flu as the elephant that people don't see in the room with them. Once you do, though, it's really hard to ignore the threat it poses. I was primed, though, to take this story seriously. I live in Toronto and I covered SARS. I watched what a simple, not very highly transmissible virus did to a modern city with some of the finest healthcare facilities available, a city snugly situated in the developed world. For 4 months in the spring of 2003, SARS turned Toronto on its ear. Hospitals were locked up tighter than a drum. No visitors were allowed in, even initially not to comfort the dying. In the early stages, all non-urgent surgeries were canceled. Cancer biopsies, joint replacements, organ transplants, and other important health procedures were delayed. to the anxiety of the affected patients and their families. We journalists weren't allowed into the hospitals at that point, but by all reports, they were in chaos. Healthcare workers were exhausted and petrified they'd get sick, and in fact, a lot of them did. 43% of the cases in our outbreak were healthcare workers, and 2 nurses and a doctor died. Healthcare workers were even more frightened that they'd bring the virus home and infect their family, and indeed that happened as well. And some will privately tell you that although they turned up for work, there were others who called in sick or who pulled rank so as not to have to treat SARS patients. In the community, about 20,000 people were put into quarantine for 10 days apiece because they'd come in contact with somebody who went on to develop SARS. This is a paramedic who's doing an interview on the balcony of his apartment. Eventually, the World Health Organization told people not to go to Toronto, and while that angered our political figures mightily, it didn't really change very much because the damage had already been done. By that point, tourism in the city had plummeted, hotels were empty, major conventions had canceled, movie shoots moved away, concerts wouldn't come to Toronto. Billy Joel and Elton John refused to come and play in our city. Theater shows went dark for a period and some of them closed. The Lion King is no more in Toronto. Restaurants, particularly in Toronto's bustling Chinatown, fell on very hard times. People just hunkered down and stayed home. And that all, of course, will happen when a pandemic starts. Governments may or may not move to close their borders and block international flights in and out of their countries. But as Australia's Health Minister Tony Abbott mentioned recently, I don't think we'll need to close the borders because people simply won't travel. That will have a huge impact on the hotel and restaurant industries worldwide and on the people who work in them, and as well on airlines. And grounded planes mean grounded goods. But let's go back to SARS for a second. Severe acute respiratory syndrome was a frightening event in medical history. Don't let anybody tell you otherwise. It sent shockwaves through the economies of Asia and Canada. But for all the panic that was attached to it, there were only really 6 true outbreaks of SARS in the world: China, Vietnam, Taiwan, Singapore, Hong Kong, and Toronto. All that fear, all that economic disruption, and only 6 real outbreaks. What will a global outbreak of disease bring? From my perspective, SARS should have taught us a couple of key lessons, and the first is that in the modern world, infectious diseases travel at jet speed. Pandemic planners tell us we may have up to 3 months before a pandemic virus hits North America. I have no idea why they're so optimistic. SARS was rampaging through Toronto hospitals before it even had a name, before the WHO warned anybody to be on the lookout for the disease. The second lesson, and this is something that was tragically driven home earlier this month in New Orleans, we are not very well prepared for emergencies. And the third is that it doesn't really take very much to tip systems over the edge. In the case of healthcare systems, at least in my country, there's virtually no surge capacity. On any given day, in any given city, most beds are claimed, especially in the acute intensive care units. A bad flu season or an outbreak of norovirus can easily swamp emergency rooms around the city. How then do we expect them to cope with a crush of patients a pandemic will bring, the hundreds of thousands the mathematical models predict? Don't forget, these numbers are in addition to the load that hospitals are bearing day after day. And they could be very optimistic numbers, as Dr. Osterholm's presentation suggests. One of the most commonly cited mathematical models was devised by a delightfully outspoken health economist at the CDC in Atlanta, Martin Meltzer. He deliberately used conservative figures, attack and fatality rates, based on the relatively mild pandemics of 1957 and 1968. Nothing like the carnage of 1918 with the Spanish flu. He even devised a program called Flu Surge, which hospital administrators can use to try to figure out what the demand for care will be in their catchment areas. He says when he runs that program for hospital administrators, they invariably blanch. And then there are the fatality projections. You see lots of them, and they are confusing. They're all over the board. The first, and the most conservative, is the WHO's estimate of 2 to 7.4 million. That's extrapolated from Martin Meltzer's model. The second is a number that's been floated by Dr. Shigeru Ami, the director of the WHO's Western Pacific Regional Organization. I've never seen anything to indicate how he's come up with this number of 100 million fatalities. The third is a number that Dr. Osterholm used in his foreign affairs piece, 180 million to 360 million potential deaths. And that's looking at the population now versus 1918 and looking at breaking it down into age groups and laying the two across. The final figure, which has been used by a few people that I've seen, and most recently by Erwin Renletter, the director of the National Center for Disaster Preparedness at Columbia. I don't have any idea how that figure was arrived at, though it looks to me like somebody took the world's population, assumed a 30% attack rate, and a 50% fatality rate. That's a lot of assuming, I think. At the current time, there's really no way to know what the numbers will be. But what is clear is that whatever the number will be, it won't be very pretty. During SARS, doctors came to Toronto from across Canada to help out, and they even came from the United States. And the same thing happened as it should have when Katrina decimated New Orleans. Paramedics from Vancouver drove themselves to Louisiana to pitch in. In a pandemic, every jurisdiction is going to need every single doctor, nurse, lab technician, orderly, and paramedic they can muster. No one's going to be able to rely on the cavalry arriving. So how are we going to cope when the whole world gets sick in a pattern that could resemble a wave at a sporting event? How do businesses continue to function when a third to a half of their workforce calls in sick? How do crops get harvested? How do grocery store shelves get stocked? What does it do to our families, our economies? Sherry Cooper is a very prominent economist in Canada. She works with BMO Nesbitt Burns. It's a brokerage house. She and a colleague recently did a report on the potential implications of a pandemic, and she came to the conclusion that economically it could have an impact similar to the Great Depression. This all creates enormous dilemmas for governments. How do they prepare for an event that may or may not happen in their mandates, that may or may not claim millions of lives? How much can they afford to spend on drugs they may have to junk because the drugs expire before the pandemic happens? The experts tell us a pandemic is inevitable, but there's no way of saying when, and there's no way of saying how bad it will be. What they can tell you is that planning for such wide-scale illness is an enormous endeavor. Pandemic planning isn't easy, it isn't cheap, and it isn't equitable. Many countries won't be able to afford any measures at all, let alone the expensive measures we in the West are looking at. We need to remember, though, that even if we manage to help ourselves, many of the comforts of our daily life, lettuce in winter, light bulbs, new sneakers, are grown for us or made for us by people who live in developing countries. If their workforces are decimated, we will feel the knock-on effects. The people I've spoken to who are doing pandemic planning liken it to peeling an onion. Every time you take off a layer, you discover something else that needs to be planned for. Things like security for the eventual vaccine clinics to ensure that it's administered in the order of who needs it most, not who shows up with a gun. Or finding ways to keep hospital laundries functional or to feed hospital staff who'll be working around the clock. The most sophisticated plans are broadly based, reflecting the fact that there isn't one single way to fix this, one single way to mitigate the blow. It's hoped antiviral drugs will help, but they're in very short supply worldwide, as Mike was mentioning, and only a few governments are spending the huge funds needed to buy enough drug to protect a large portion of their population. And antiviral drugs are a very expensive crapshoot. They could expire before we need them. As well, there's always the possibility the virus could mutate and develop resistance to the drugs, and then they would be rendered useless. And while there are a growing number of governments in the queue to buy these drugs, because of the limited global capacity to produce them, as we heard earlier, what we're reading about in most cases are orders, not deliveries. Many countries won't take delivery for several months, maybe several years. Vaccines should help a small portion of the world's population, and with present production capacity, only a very small portion of Americans. But with existing production methods, they won't be ready for at least 6 months, as we heard earlier, and that could be easily after the first wave has swept through and wreaked whatever damage it's going to do. Vaccine is an answer, but it's not the answer. We heard the math a bit earlier. There's a global capacity to produce about 900 million standard doses of 15 micrograms in a single year. But each person will likely need 2 doses of a primer and a booster. The NIH vaccine trials you would have read about recently found that to get a good response, each person needed 12 times the average annual dose of vaccine. So if you do that math, that means the world can produce enough vaccine in 1 year to protect 75 million people. And as Mike was saying earlier, you can assume that if vaccine is made in one country, it's not going anywhere until every single person in that country receives vaccine, whether another country has paid for it or not. Canada ran into that problem in 1976 with the swine flu scare. We had ordered vaccine from US suppliers and we couldn't get it. As a consequence, our government became extremely concerned about pandemic planning, and that was the catalyst of a plan that involves having a vaccine manufacturer located in Canada on contract to the Canadian government to be at the ready to make vaccine whenever it's needed. But the US doesn't have that kind of capacity. Currently, domestic production is limited to the Swiftwater, Pennsylvania plant owned by Sanofi, which makes about 180 million single doses of vaccine a year. If some way isn't found to improve the dosing needs that the NIH study identified, that means the United States can produce enough vaccine in the first year of a pandemic to protect 15 million people, or about 5% of your population. Try to imagine what the chaos will be at the vaccine clinics if that's the case. Much more vaccine could be made available if companies and countries move to what are called antigen-sparing strategies. Those involve, there are a variety of ways of doing it, but the way that's felt to hold the most promise involves mixing something called an adjuvant with the vaccine. You get a bigger immune bang with a smaller amount of antigen. That could significantly reduce how much antigen each person would need and substantially increase the number of people who could be vaccinated. But those kinds of vaccines require new licenses, and the studies that would be needed to push those vaccines through the system haven't even started yet. And even if vast supplies of additional vaccine are produced, there could be downstream problems. Are there enough syringes to administer it? Alcohol wipes? Are there facilities for vaccine clinics and people to staff them? And will there be enough healthy police or armed security guards to protect the clinics in the early days when the supplies are very limited? The people doing planning have to also think about stockpiling masks. As you heard earlier, they're in very short supply globally. They need to line up facilities for overflow hospitals and figure out how to staff them at a time when healthcare workers will be falling sick at least as quickly as everybody else in the population, and they need to find places to store bodies. In our countries and in some others, people are making progress on this work, but they may be juggling it with other public health demands on their time, and they are certainly in competition for scarce government resources. And to some degree, they seem to be doing this with blinders on. It's like everybody thinks that if they can only get the money for their needs, all those goods will be out there. There's a great big medical warehouse where they can put in their order and get all the masks or all the syringes that they can need. They don't seem to be aware that every single jurisdiction is going to be facing the same needs at the same time. There also seems to be this sense that there are limitless amounts of Tamiflu, and if only governments would pony up, we'd all be fine. Another observation I would make is that as of yet, governments are not involving the public to any degree, nor are they urging individuals or businesses, for that matter, to start thinking about measures they should be taking to ready themselves to ride out the storm. Countries that have pandemic plans that include vaccine and antivirals have or are in the process of drawing up priority lists of who will get the limited supplies and in what order. But I know of none that is sharing that information with its populace. Think of what's going to happen when the vaccine is ready and people go and line up and you're told, I'm sorry, you're a healthy adult. Get to the back of the line. Or how about this one? Your daughter's got asthma. We have drug for her. Your son's sick too? I'm sorry, there's nothing available. A small number of individuals are twigging to the threat. There's a burgeoning number of blogs and discussion boards on the internet that focus on pandemic preparedness, and individual sales of the antiviral drug Tamiflu have surged in a number of countries. Yours, mine, New Zealand. Apparently right now you can't buy it in New Zealand. But to date, no one has really engaged the public in any kind of a debate about what might be coming or how we can help ourselves get through it. In the time I've been covering this file, I've seen the threat of pandemic influenza go from barely being in the kitchen to a back burner issue inching its way to the front. But there are a lot of challenges ahead and a lot of difficult decisions to be made. And we don't know how much time we have to do the types of things that could turn a pandemic from a gigantic catastrophe, as David Fedson puts it, to an ordinary disaster. Thank you very much.
Well, terrific. Now, if we are not all frightened into silence, we have some time for some questions. We have microphones on the side that my colleagues will bring to you if you have questions. We ask that you tell us who you are before you pose your question, and questions, please, not extended comments, so we can get through as many as we can by 1:30. So who would like to kick us off? I see a couple fingers up there by you, Charlotte.
Edward Levine, Senate Foreign Relations Committee. Wonder what your reactions are to the recent studies that ran computer simulations of an outbreak in Thailand and came to the conclusion that it might be possible to stop an outbreak there if people had enough antiviral medicine.
Thank you, Edward. Let me just say at the outset that I, again, recall back onto my 30 years of practical public health experience, having in this country led some of the biggest outbreak investigations that we've conducted, and I think to date still oversaw the largest single emergency vaccination clinic program for meningococcal disease in one community in Minnesota. I will use all that to then add the caveat that I am one who believes that at best is very wishful thinking. For a country to initiate an event like that, first of all, you have to document that you've got person-to-person transmission now constituting a pandemic. This is occurring in many countries where the infrastructure is so poor, we're lucky if days later we can even find out a case occurred. Second of all, you have to have laboratory confirmation. Third of all, and this is all going to require a very speedy identification and ascertainment. What country is going to pull the trigger to say we have a pandemic beginning in our country, bring in all the Tamiflu or whatever? We're shutting down all trade and travel. We are now going to become the black hole of the earth and not do it without an incredible amount of information to support that conclusion. Because if you're wrong, the implications will be very far-reaching. Well, by the time you actually are able to accomplish that data collection and assure enough people throughout the political, economic, medical, public health world that that's the case, as Helen demonstrated with SARS, that virus will be all over. Finally, the analysis made the assumption that this was a one-time event, as if lightning only strikes the world one time. You could see many of these situations occur where even if they're false alarms, where you then would say, well, we wanted to act quickly enough to be sure, so we stopped travel, and we had that ability to do that. We gave out drug, but it wasn't really it. And now we got to do it again and again. And they never looked at the cost of stockpiling for reload, for the idea that this might happen over and over again. And therefore, because we see no foreseeable future, we can one day say it's done. You know, until we have a vaccine for every bird in the world that's effective, or for every human in the world, this will likely play out for many, many years to come in terms of H5N1. So I don't see any practical possibility for this to happen. And what I worry about is that today we are looking for easy fixes. We have lots of happy talk and easy fixes, and we've got to understand that that's not in anyone's best interest. And so I would really urge that we not bank on this as, well, we can stop it there as the easy answer and allow ourselves to be lulled into a sense of complacency when, in fact, I don't see any conceivable or practical way in the world it'll ever work.
Could I add something? This morning, the WHO posted a death that occurred to H5N1 in Vietnam. It was a case that happened in July. They just got confirmation. If we need any more evidence that this isn't going to happen in the time frame that it needs to happen for that plan to work, I don't know how you could get better evidence. As well, I would point out that right now, Jakarta is having quite a problem, it seems. Today there are rumors of 2 or 3 additional cases, depending on which reports you read. The modelers themselves will admit to you that they modeled based on a rural outbreak. Their model doesn't take into consideration an outbreak in a large Asian city. And they will tell you, if it happened in Bangkok, if it happened in Jakarta, it won't work.
Yeah, please, gentleman down here.
Yes, my name is Frank Giordano, and I work for the Department of Defense. And my question is, in regard to the statement that 40 nations have developed plans, number one, is China one of them? And are most of the countries where the outbreak of the avian flu have occurred, are they among these nations who have developed plans?
Do we have wireless? Can I check the WHO site? I'm sorry, I don't really know at this point if China, there is a list on the WHO site, and I'd have to refer to it. I'm not certain if China has or not. I would tell you that some of the plans are much more detailed than others. I believe Thailand has a plan, for instance. But some of the plans are very, very basic and may not be as in-depth as yours will be when it comes out, or ours is.
At the risk of sounding like I am from the Midwest, let me say I don't want to beat a dead horse. But in fact, if we learn nothing from Katrina, we learned that plans are just plans. And the bottom line is that how exhaustively, comprehensively, and thoughtfully have they really been exercised? Have they really been thought through? Remember, if you have to go A plus B plus C plus miracle equals the answer, then I'd say that's kind of a fluffy equation. And far too often, many of these plans make assumptions of resources. They make assumptions that you can't back up. If you run out of supplies, those plans don't work. One of the other areas that I deal with a great deal is in the area of the food side, and food safety, food protection. And I can tell you right now that 30 years ago, when the Green Giant harvested corn in the Midwest, they canned it, put it into a warehouse, and over the next 10 to 12 months, that corn was brought out in cans. Today, they harvest a field. Those cans go into actual retail wholesale distributions within hours and are distributed within days. And every day, new fields somewhere around the world are being harvested. Today, our food supply no longer is part of a warehouse system. It is an overnight, just-in-time delivery system where some grocery stores today literally get milk deliveries twice a day just to keep milk on the shelves because it's just-in-time delivery. I haven't seen a single plan anywhere that's even thought about how we deal with the interruption of the food supply for an entire world. When we think about Katrina, we're thinking about 47 states helping out 3 states. We're thinking about retail. Do you know right now that in the southeastern part of the United States they're having problems delivering groceries? Because FEMA put out a premium contract for all refrigerated trucks to sit by wherever in case they needed them. And suddenly the grocery industry realized they didn't have any refrigerated trucks to bring their products to market, and they're really suffering in the southeastern part of the country. We haven't thought through almost any of the implications of these things. So for a plan to really be a plan, we've got to take a step back. And I'm one of those, and I said this in a comment Friday night after one of my congressmen actually gave me permission to say this, Jim Ramstad from Minnesota, is I don't want to go to another congressional hearing or another state legislative hearing and hear all this happy talk. We are, as government entities, conditioned to go and put our best foot forward, because if we don't, we're going to get nailed. And somebody will take a partisan shot, or somebody will accuse us in the media of being incompetent. It's time to let all that go. We need to go to an AA meeting where say what you mean and mean what you say. It's the only way we're ultimately going to really get better prepared. Second of all, we need to adopt, I think, a world of discovery and response like the airline industry. Today, if I self-report a mistake in the airline industry, there is no punitive punishment or damage. What is instead done is there is an attempt to understand what went wrong, why, and how do we fix it so it never happens again. In this world of public health preparedness, in government today with its partisan nature, everybody's covering their butt all the time. We can't continue that and really have an honest and intellectual discussion about what are those events that are so catastrophic if they occur, they threaten the state of the union or the economy of the world, whatever, and so what are we going to do about them and not fear retribution? We've got to have that discovery. I would just make one last point. I'm not here to apologize for anybody. There were major mistakes made in the Cortina response. But let me just leave Washington, D.C. with one thought. How would the capital region have responded if a 180-mile wide F2 tornado came through this area and then dumped 6 to 20 feet of water on it? You know what? There wouldn't have been any local response here either. But we got to start thinking about that then. So if there's not, then what is the response? What should have happened? Who should have picked up the pieces? And I think Helen said it very well. When pandemic flu hits, there will be no cavalry coming anywhere because we all will be the cavalry. Every location, 50 states, every large city, every country will be on their own. And I think that's an important part. Is that in the plans? No.
Okay, gentleman on the side there, Hope.
Thank you. My name is Jeff Lee from Stanford University. I was particularly struck, Dr. Osterholm, by your data on China. Two quick follow-on questions. One is the growth in the number of pigs, poultry, and people, particularly since 1968, is fascinating. I was wondering if you could tell us more where you get your sources from, where you get that data from. And the second follow-on question is, if China is this hotbed that everyone thinks it is, I noted with interest your map, which looked at the places where there had been human cases and animal cases, and China only indicated animal cases. Do you judge, in your opinion, that there are likely human cases there, or what is the reason for that discrepancy? Thank you.
Yeah, thank you. That's a great question. And let me just say at the outset that I only use China as an illustration. Actually, you can take all of Southeast Asia, and you'll see very similar pictures of growth for a number of the countries in animal protein production and what happens there. So, for example, up until the recent H5N1, Thailand had become the number 3 exporter of poultry in the world. So that I just used China, and I'm glad you allowed me to clarify that. As far as the numbers come from, interestingly enough, we probably count animals in the production side in this world better than we do people, just because of the economic implications. So the FAO, other organizations actually have extensive databases on these kinds of animal production issues. And so that they're there, and in fact there's a wonderful map that the FAO has put out that actually gives you by province the actual concentration of these animals and where they reside. I think the issue with China is one that I believe that there is more transparency today than there has been in the past, but I still don't know if we all understand the extent to which there may have or not have been illnesses in China. I think I would rather look at all of Asia in the Far East as really the hotbed. People have asked, well, what happens if this virus comes to Europe or the Americas through migratory birds? I don't think, frankly, it is a great public health concern in the same way that Asia is, because in many of our areas we could have poultry-related outbreaks for the wild birds mixed with the domestic birds. But when you look at the actual genetic reassortment pressure, what I call genetic roulette, the pressure will remain in Asia because that's where the people, the pigs, and the birds are at. And so that anything else outside of that surely could lead to that ultimate tipping point of accumulation of point mutations or something, but the pressure will remain in Asia in terms of that happening. And as I pointed out, when people talk about, we culled 300 million birds last year, think about the fact that we're harvesting billions and billions of birds every year and growing new ones the same day so that we can maintain that food supply. And so we have this almost unlimited supply of quote-unquote fresh susceptibles that are going to allow this virus to maintain itself in the foreseeable future.
John Waugh, down front.
Hi, John Waugh from IUC and the World Conservation Union. I took some time off today from the summit on amphibian conservation that's taking place across town to come here for this, because over there's a discussion about what some would characterize as a pandemic that is affecting amphibians worldwide, and there's a variety of factors that contribute to that, and the approach that people are describing in terms of how to understand what's going on, the mixture of environmental and epidemiological factors, is they're calling landscape epidemiology, and it's of considerable interest to me that the ecological dimensions of emerging diseases, zoonotic diseases, and my question to you is: do we have the capacity, and is there the investment up front in understanding the factors that contribute to the emergence of diseases and the monitoring of those factors in order to prevent future things? I noted that one of you mentioned that this is not a one-off event that we're talking about, but something that's likely to happen again and again. So I wonder if going beyond the avian flu epidemic, how we're dealing with what else is out there.
Well, let me take a start at it, and then Helen may add to it. But first of all, you raise a very important point. And anyone who is following new emerging infectious diseases today have to understand that the vast majority over the past 30 years have been zoonotic diseases, i.e. diseases transmitted from animals to man. And this connection is absolutely critical of understanding that. So when we basically destroy the rainforests of parts of Indonesia and the bat populations migrate from there to the rainforests of Australia and bring Nipah virus with them into an environment where we're now encroaching on the rainforest of northern Australia with our hog and horse farms, and suddenly we've put Indonesian bats with hogs and horses, and we suddenly have outbreaks of a disease we'd never heard of before. That is about as cause and effect as you can get in terms of change and what that means. So I think your point's well taken. I would just add a reflection on this with pandemic flu, though, which I think is a key one. I must honestly tell you, I knew a hell of a lot more about influenza 5 years ago than I know today. And the more I've studied it, the more I realize how arrogant we as a human population tend to be with what we know for certain, particularly when it comes to Mother Nature-related events. But I've become a student of the history of influenza and have gone back and have begun looking carefully at all those pandemics I talked about. And I was amazed to find out that in 1530, pandemic influenza again emerged in what is now roughly the area of Beijing and landed within that 6-month period into what is now Istanbul. Over the next 6 months, it spread completely across Europe. Now that's in 1530, at a time when, if you look at the whole transportation system, etc., you realize that it took a heck of a lot for that to happen. So today we've made so many ecological changes, and that's why that first slide I showed you, that's my mantra slide. You know, it's a world in utter change. It's a calculus-like change where the rate of change continues to increase. And so I think that if flu did well back when there wasn't a war, like World War I, when it did well when such things as international travel were unheard of, when it did well when population densities were many, many, many times smaller, both for animals and humans, how is it going to do today? And I think that's what we have to consider. I don't see any one reactor rod that we can put into the reactor to stop this today. The only thing that I could imagine tomorrow is if we could develop vaccines that could somehow be readily administered to large parts of the domestic bird population to keep it from going from birds to those wild birds to domestic birds pigs, etc., and make that economically feasible and doable, as well as a human vaccine, which would cover a variety of different influenza strains. I mean, that's my goal, that's my hope. And short of that, I don't see anything that is really the reactor rod that will stop this.
Were you asking about surveillance? I mean, are you also interested in knowing how much surveillance there is in how well equipped we are to detect emerging strains?
Well, there appears to be a fair amount of surveillance of diseases. What I'm talking about is understanding the dynamics with regard to the emergence of diseases.
Right.
What are the ecological and economic factors that contribute? Can we be proactive, or do we sit back and wait for the next one to happen?
Well, one point I would make is we've never actually, in history, had the opportunity to watch an emergence of a pandemic. So we don't know what we're looking at. You know, this may be the opening steps, these may be the opening steps of the dance, but we really don't know because we never had the technical capacity to test in this way previously. So I think that makes it a little bit hard to say. I am constantly surprised at how little people know about influenza, and I'm talking about experts. I am routinely hear things exactly like Mike just said about when you ask people, what does this mean? People say they don't know. I mean, you said you're from the Conservation Union. People have no idea what role wild birds are playing in this. There's a huge argument going on, even though the FAO has said the wild birds are going to bring it to Europe. If you talk to bird experts, they don't believe that that's the case, but nobody really knows for sure. So I kind of think we're in a bit of a position where we'll be a lot better prepared next time. But right now, we don't know what we're watching.
Gentleman here, and then the back, and then come down to Linda.
Joe Snyder with the Asian Society. I have a question for Dr. Osterholm, which may sound cute, may sound partisan, but is not. Given what we've heard from you, why haven't we heard this from your bosses, Chertoff and Levitt and Bush?
Well, first of all, I don't take that as cute, and they're not my bosses, fortunately. The Center that Homeland Security supports is at the University of Minnesota, and my boss is the University of Minnesota. But for honesty's sake, I did serve as an advisor to Secretary Thompson on a part-time basis while at Minnesota on preparedness side. I think several things. First of all, my understanding is the President has taken this very seriously and is considering some very major increased efforts in this area. Why it hasn't happened before now, I think it's about Washington. Right now, in an environment where we're talking about how are we going to cover the cost of Katrina, how are we going to maintain a war, how are we going to maintain tax cuts, how are we going to maintain all these things, we are mired down in partisan politics. And very few of the real planning issues that we really need to get to rise to that. But that's not just true in Washington. You know, I again served in state government for many years where I had to go to those legislative committees, and you know, I was never a good witness because I always believed it was my job to tell the truth, not what the party line was. And so that didn't always endear me to some of my bosses. But the point of it is, we very rarely find government officials who are willing to speak the truth or who are willing to acknowledge the truth. I mean, we all have a built-in innate desire to please and to assume we're doing a good job. I continue to come back and say, you know, let's just call a moratorium to this. No harm, no foul, what happened in the past. But from here on, what are the real issues? What is it that we really have to do? And don't make it a partisan issue. And so I think that's part of it. The Hill hasn't added its expertise. I mean, where's the Hill been on this? You know, we saw after the influenza vaccine crisis of a year ago, again, on a bipartisan basis, this came through. We got to increase America's vaccine production capabilities, so they nibbled at the edges. You know, we could do a little incentive here to let. They didn't cover the big picture issue at all. They never went to the heart of it. We've heard various elected officials talk about Manhattan projects. We've heard people talk about over the years the need of this. Where's the action? So I think this is a no blame, everybody blame game. And the bottom line is, it's now the time to make a decision. Are we going to really learn that we have vulnerabilities we've not covered? Take at least an effort to say, we can't stop everything. So those things we can't stop, or we can only do a little bit about, you know, but they're not that great of catastrophic events. We just can't prepare for them. We can't cover all things. But for those few things that we've determined, and I must add, ironically, one of my dearest friends is John Barry, the author of the book about the 1918 pandemic, and also coincidentally the author of The Rising Tide, the book about New Orleans and the flood that resulted in the levee system and the vulnerability. And I've been talking about New Orleans substantially for the last couple of years as an example, again, of not getting it. You know, this is another example. This doesn't have to be a partisan issue. So I would say, more importantly, to take your question and turn it around without being cute, where is all of our elected officials? Where are all of our leaders? I watched the Sunday talk shows yesterday. I saw mayors of large cities, governors of states, who all had happy talk. We're prepared. We can cover it. F5 hurricane hit Miami. We're okay. I mean, we got to stop that. And we've got to be honest. And so that's where I think it is. And I don't care what party you are. I don't care where you're at. And some people are going to get left out when we do the analysis. But for some, we'll understand if this is what we do or don't do, then this is what will be the consequences. And this has clearly got to be at the top of the list.
Okay. Gentleman in the back, and then we'll make our way around. And we have a lot of questions, so maybe, in fact, what I propose we do is why don't we collect a couple to give you guys a chance to respond to maximize people's opportunity. Please, sir.
Thank you. I'm Dan Singer from the State Department. I would preface my question with the suggestion that the political will that we have here, albeit still insufficient, is much greater than it is in many of the countries that are most affected in Southeast Asia. That said, I think one of the biggest challenges in developing political will is giving policymakers something concrete. As both of you have acknowledged, there's tremendous uncertainty in every aspect of the virus and its epidemiology. And my question is, are there tools in predictive epidemiology, are there tools in genetic analysis that are giving you any better sense of potential mortality other than the 2 orders of magnitude that were presented to us? Are there other pieces of the potential pandemic that you think we may be able to be more concrete about predicting that would give us the information we need to really nail people down and say, here's the number of new caskets you're going to need, here's the number of hospital beds you're going to need?
Okay, great. Let's take a couple more. Gentlemen right here in the middle, and then Hope, if you could come down and give it to Linda.
Hi, my name is Prosser Sterling. I'm from Oracle Corporation. I'd like to ask you if you could discuss how IT, information technology, can serve you as a tool. One, what will the needs be in development, software development? What will the needs be in infrastructure? What will the needs be for IT management, that is the role of the CIO, both in preparation and response?
Terrific. Linda?
Dr. Osterholm, could you please explain how human vaccine, which is intended to boost the immune system, would be effective against a strain that actually is caused by an overactive, the majority of the deaths are caused by the overactive immune system? So,
let me just say, by the sake of the questions we have here, I wish you all were in charge. Maybe more of you are. Do you want to start? Or
The gentleman at the back, I don't know that there are tools, and that's really more Mike's area than mine, but I'm not certain why it makes any difference. It's an order of magnitude. If 1 billion people die, if 380 million people die, if 7.4 million excess deaths occur in a year, it's still going to be hell. And those are just the deaths. Those are not the knock-on effects. Those are not the fact that people are going to not find food in their grocery stores. You know, I don't know why. There will be a pandemic, whether it is this one or it's another one. There will be a pandemic, and because of the interrelatedness of our world, it's not going to be much fun. And so why do you need a precise number to be able to know that planning has to take place?
And let me just respond to that also, because I think, first of all, let me acknowledge your point. I think our country right now is leading the world in trying to push this issue in an international way, and I give our country credit for that. And I think there are a couple of people at the Department of Health and Human Services who have particularly been joined in that, both in Southeast Asia and Europe and so forth, and I give them credit. The problem is when you have a 6 foot lifeline and the person's 30 feet out, and you got to throw it to them, we got to get more lifeline. I think the point, though, you raise is one that I would come back and say that's one of our problems today, is that we don't look at the whole entirety of what the situation will ultimately mean. I, for one, just so you don't think I'm always bad news Mike, made a prediction a week ago that I would be very surprised if the number of dead in New Orleans exceeded 1,000. When everybody else said it was 10,000, I could not understand how we were going to get to that. And I believe it'll be less than 1,000. But what's the difference? Whether it was 10,000 or 1,000, you saw the implications of that event. They are far more than just a body count. They are the entire ripple through. The fact is, it's when your mom can't get her cancer drugs, and we don't have caskets to bury people. I was in Chicago for the heat-related epidemic that occurred in the 90s, and I saw those refrigerated trailer trucks and the psychological impact that that had because they couldn't process bodies fast enough. And it was incredible. And so I think that part of it is it won't matter in the end. Remember SARS, 8,000 cases, 800 deaths. And that was, in a big picture of public health, not even a real blip. Yet the implication of all the other factors went with it. So I think that's what we have to focus on. IT-wise, I don't know what IT has to offer in a sense of when we get into this, it's going to be basic survival. And I don't know what IT, other than the classic internet-based system. I will tell you, I do believe this. IT will basically crash. And people aren't going to be buying computers. There won't be chips to be had. Whether you're in the jewelry business, the entertainment business, the automobile industry, the airline industry, the IT industry, those businesses will crash. For 6 to 12 months, I think they're done. And because what consumer is going to be out there worried about getting their new computer when they're worried anywhere going somewhere to get it, or who's going to deliver it to them, or who's going to be in the warehouse to get it, or who's going to build it? We saw in Taiwan, and Barry Lin, who happens to be in the audience here, wrote, I think, a remarkable book, The End of the Line, and he's going to be talking here in a couple of weeks. And he talks about the implications of the supply chain when basically just one rock gets in the gear and the implications thereof. I'd urge all of you to read it. It's a remarkable piece. And even as a neophyte economist, or I'm not even that much, I found it helpful. So I think that's the case. In terms of the vaccine, let me just say, you raise a really good point. The issue of protecting yourself with antibody before the virus is able to proliferate is what you want to do. Once it starts to proliferate, that's when it sets off the cytokine event. So actually we can get ahead of it, we believe, so that in fact it won't be, as you suggested, which is a very good question, by the way, because it makes perfect sense. If antibody or the immune system is part of it, there are many arms to the immune system, and this one of antibody and certain cellular production that the vaccine can induce will hopefully stop it from crossing over into that cytokine production. So I do believe a vaccine will work.
Okay, gentleman down here in the white shirt, and then we'll go up to the back for the last question.
I'm Rob Taylor from International Center for Journalists. I'm interested in whether there is anything that a host country can do to stop, that's overstating it. I think you've already said you don't think it can be stopped. Can a host country retard the spread of the virus once it breaks out locally? And a lot's been made of how China tried to keep quiet the SARS outbreak initially. I think China's becoming more aware of the need to have more transparency, but I think there are a lot of countries that their initial response is going to be to try to keep things quiet and not cause panic. But is there anything that they can do if they are in a position to act rapidly?
Okay, and ma'am, could you?
Hi, I'm Christine Craig from 21st Century Science and Technology magazine, and you pinpointed the global just-in-time economy as being one of the huge problems, no matter what the pandemic is. Mm-hmm. No matter what the problem is, that as soon as you throw one wrench in, the whole thing comes to a screeching halt. And so how do we go back to a case where our national security requires that we have certain things within each country to keep that country going, a certain amount of infrastructure that will keep that country going no matter what happens? How do we go back to that kind of farming and manufacture, et cetera?
Can I answer that? I mean, he has a much more informed answer, I'm sure, but I think for starters, we as taxpayers have to allow governments and those of us who are stockholders have to allow companies to build in surge capacity. We don't want to pay for it, so it isn't there. But without it, we're very, very vulnerable.
Yeah, let me just, in response to your question, I think, again, you raise a good point. My model has been, what are those critical products that we need to get us through a pandemic in terms of things like food and water and so forth? I mean, something as simple. Do you know how many manufacturers of municipal water pumps there are in the world? Do you know what the supplies are for replacement parts? Do you know the age of many of our pumps in this country in our largest cities? And what happens today, often they literally go out, and if they don't have overnight delivery of a replacement part from some other part of the world, that pump offers irreparable harm to that city's ability to deliver water. I mean, there's just so many parts of our world we haven't looked at in terms of critical infrastructure. So I'd say food, water, just how we're going to handle hospitalization. I do believe ultimately how we handle the dead will be a very key part. It will define us as a human population and what we do. And it will also define, I think, the psychology, how people respond. And I think that's going to be important, and we've not really worked through that. So I think there are key things like that. Let me just add, we do make some conscious decisions, or unconscious potentially, about doing this. If you look today, some of the most well-funded fire departments in this country reside at international airports, for which about the only thing they ever really do is supply ambulance service to the terminal or to the workers. Yet we pay for that day in and day out, because when that crash does occur, like it did in Toronto, you have to be there right now. And we've made a decision in airports that have not had a major plane crash in 40 years, we'll pay for that. So I think we have to make some decisions about what are the key items that we have to get through, and we're going to pay to stockpile, to build the plants, to make them, et cetera. And all I can do. I think in regard to your question, you asked, I'm sorry.
The host country, are you talking about like Vietnam or somewhere in Asia, or are you talking about if it came to, wherever it comes from, you mean?
No.
Earlier there was a question about some studies that were published earlier this summer in Nature and Science. 2 modeling groups looked at whether or not that was possible. They came to the conclusion it was, with with a lot of caveats and a lot of luck. The WHO is committed to trying to do it, but I have to tell you that at every level there is great skepticism about.
And let me just add a piece on about influenza. When I was a state epidemiologist in Minnesota, for those who haven't thought much far west of the Hudson River or the Appalachians or Alleghenies, Minnesota is a state that it takes 14 hours to drive by interstate from the northwestern part of the state to the southeastern part of the state. Okay? And it's a state where, as a state epidemiologist, I was always amazed. It never, ever was lost on us that when influenza finally came to our state, on the same 24 to 48 hour period, we'd suddenly see outbreaks in schools and nursing homes in the northwest part of the state, in the southeast part of the state, in the southwest part of the state, in the northeast part of the state. I know of no other infectious agent from a respiratory standpoint that is as efficient as being transmitted as influenza. Take SARS, take smallpox, take so many other agents. They're much, much less efficient. And so if you are, in fact, infected with influenza, we really believe that the potential for transmission is of a magnitude that it will be, with every public health tool we have short of an immune-protected population, i.e. vaccinated, will be virtually impossible to stop. I don't believe quarantine will work. I don't believe closing the borders will work. It'll slow it down, potentially. The other thing I would urge is if we do close our borders, it's like, how do you unring a bell? What are we going to do to open them again? When do we decide we're going to open them again? We haven't thought about any of those issues. And so I don't think host country is going to make any difference.
The other thing that, I don't know how much you know about influenza, but influenza is infectious before you know you're sick. Which, with SARS, it was a great disease for quarantine. It brought quarantine into the modern age because you could put people, in quarantine and wait to see for 10 days if they exhibited symptoms, and if they didn't, you knew they were fine. But with flu, I mean, you can be passing the disease to people before you have any idea that you're sick. So how do you contain it with quarantine?
Okay. Well, I'm afraid we've come, in fact, past our appointed time. There's obviously, there are a lot more questions, a lot more to say about this. I will urge you to come to the Wilson Center website where, A, you will find the archived video of this program, but also a summary that allows you to engage in discussion and add your 2 cents, and in fact, maybe even post some questions. We hope to have the PowerPoints there as well. And as I said, look for some additional programming on global health and avian flu in particular here at the Wilson Center in months to come. So won't you all join me in thanking Mike and Helen for a tremendous presentation. Really?